hyperammonemia specifically, in the development of intracranial hypertension and ALF, particularly in hyperacute liver failure or acetaminophen-associated ALF. Talk about some of the current kind of standards in terms of neuroprotection and in attempting to prevent intracranial hypertension, and also show where the care gaps are and where some of the evidence is lacking. And then talk in a little bit more detail, and I think this is what really all of us kind of find interesting, is the role of blood purification, whether that be CRRT to start with, but also some of the other extracorporeal strategies in terms of mitigating some of the complications of acute liver failure, particularly some of the neurological complications. So for just, I know that I'm dealing with a very erudite, sophisticated audience, but just to kind of highlight again that liver failure comes in two flavors, and I'm going to be speaking about the one on the right. Well, cirrhosis is by far the most common cause of liver failure. This is a fibroproliferative process. This is generally caused by chronic conditions like hepatitis C and fatty liver and alcohol. And generally, these patients develop, well, when they develop multi-organ failure, acute on chronic liver failure. And this is something very different than what I'm going to be talking about today. I'll be speaking about acute liver failure, which is a necroinflammatory process where you get massive necrosis of the liver. And this is generally in somebody that previously had a quote-unquote normal liver. This is rare, but I think what is important about this is from a medical management point of view, whether that be on the ward or in particular in the intensive care unit, we actually have a significant impact on the management of these patients, where in many cases we can avoid a transplant and bridge people to some form of recovery. But probably one of the biggest differences that we see in ALF compared to acute on chronic liver failure is the development of intracranial hypertension, and we'll kind of go through why that is and why some of the management strategies are different in ALF as opposed to acute on chronic liver failure. So I became interested in acute liver failure because I used to call this the intensivist disease in the sense that it's a multi-system disease. And we know that just to remind us, there are a variety of different complications of ALF, including intracranial hypertension. Patients get a high output cardiac output state. They can develop acute lung injury. We're all well aware of the metabolic or hepatic complications such as hypoglycemia and lactic acidosis and hyperammonemia. And things like lactate play into some of our abilities to prognosticate with regards to potential hepatic recovery. These patients, as mentioned, can develop distributive shock, but also develop sepsis due to a form of immunoparesis. And particularly in the slower developing forms of subacute liver failure, these patients are more predisposed to infection, and certainly they can develop AKI. What I do want to mention is that because ALF is an orphan disease, I do want to kind of pay respect particularly to Will Lee and this acute liver failure study group network, which when you deal with orphan conditions, and really that's kind of classified, I believe in the US, and it's less than 5,000 cases a year in a population of 300 million. And the bottom line is that really the only way to study these types of conditions is through networks, and it is very hard to generate prospective randomized data. And in that sense, you do the best you can with regards to either small randomized studies or kind of the next best study designs, which may be propensity match studies, for example. So I do want to highlight that since 1998, this study finally, we finished enrollment back in 2019, and there are now over 3,000 cases of ALF in the registry. And also cases of acute liver injury, and these are patients that do not meet hepatic encephalopathy criteria. And just when you look at the causes of acute liver failure, and obviously this is what is one take-home point that is quite different from chronic liver disease, is that the most common cause in North America and Western Europe is acetaminophen hepatotoxicity, whether that be due to a intentional overdose or an accidental toxic overdose event. The second most common cause is idiopathic drug-induced liver injuries. So many of these are not dose-dependent. You may be aware that there is the Drug-Induced Liver Injury Network, which is also an NIH-funded group out of the US, and they've put out a website called livertox.gov. So there are a variety of different medications that, if there have been described hepatotoxic events, generally many of these are on that website. Hepatitis A and B can cause ALF, but not hepatitis C. Autoimmune hepatitis can present with ALF, but also commonly presents with cirrhosis. And then we kind of point out some of the other rarer conditions. I want to highlight that this group called indeterminate, which means that we work patients up for all these causes of ALF. And generally, we've ruled them all out, and we're left in kind of this ungratifying situation. In reality, through some of the work of the causality committee through the acute liver failure group network, probably about half of these on case review after the fact actually ended up coming up with one of these other etiologies. So the rate of true seronegative indeterminate acute liver failure is probably only about 4 or 5%. And generally, these patients tend to behave like idiosyncratic drug-induced liver injury, where they have a slow kind of indolent process. And by the time they meet criteria for acute liver failure, and what I mean by that is have hepatic encephalopathy, which defines ALF, a large number of these patients end up needing to be liver transplant, receive a liver transplant. So this kind of plays into these different phenotypes of ALF. And on one end of the spectrum, you have hyperacute liver failure, which classically is acetaminophen toxicity and acute viral hepatitis, where generally the time period from liver injury to the development of encephalopathy is actually quite short. It's usually less than a week. And these patients come in with kind of the highest burden of multi-organ failure, whether that be vasoplegia, coagulopathy, or intracranial hypertension. So they come in the sickest, and the vast majority of these patients end up in the ICU, and they actually make up about half of all cases of ALF. But paradoxically, these are the patients with the best chance of survival without a liver transplant. So this is what makes these patients both an important aspect of what we do, but also a challenge. On the other end of the spectrum, you get subacute liver failure, which these are generally your idiosyncratic drug-induced liver injury cases, where often some of these patients may initially present even to their primary care physician. They, for example, get put on an anti-epileptic or an antibiotic medication. They come into their family doctor feeling itchy. They get a bunch of blood tests done. Their ALT or AST is 900. Their bilirubin is 200. And then they kind of grumble for several weeks until they finally end up in the hospital. And at that point, they develop encephalopathy. And at that point, generally the chance of recovery, because this has been a slow kind of indolent process that's been going on for some time, the potential for spontaneous recovery at that point is not good. And the vast majority of these patients end up going on for liver transplant. And this is what we call kind of the ALF paradox, that the sickest patients in this hyperacute category, if we can manage them well from a neuroprotective strategy point of view, often we can avoid a transplant. So this slide kind of highlights again how the cause of ALF and the phenotype does impact outcome. So if you see here that paracetamol is just the British term for acetaminophen, you can see that the transplant-free survival, if you go through, this is back in 2019, the ALFSG registry, is quite high without transplant. It's almost 65%. And only a really small minority of about 9% of patients went on to get transplanted. And to put that in context, even at most transplant centers, including in Canada, the number of acetaminophen patients that we do transplant at the end of the day because of this tends to be small, even though we tend to remember them because they tend to be very difficult patients with regards to making that decision to transplant. And I'll show some data on a little bit later on why that is. And you can also see that they tend to have the highest overall survival rate. Where in contrast to this, if you look at conditions that would probably be classified as having an unfavorable prognosis, such as idiosyncratic drug-induced liver injury and hepatitis B, these patients have a transplant-free survival once they develop hepatic encephalopathy of less than 25%. So, and just to kind of take that a step further, we know that there are what we call favorable and unfavorable etiologies of acute liver failure, and I've listed them here, where acetaminophen, hepatitis A, shock liver or ischemic hepatitis, and fatty liver of pregnancy all tend to have a more favorable probability of spontaneous or transplant-free survival. But the other thing that plays into this is coma grade. And if you're not familiar with the Westhaven criteria, the reason why this differentiation between coma grade 2 and coma grade 3 is important is that generally is the difference between somebody who's protecting their airway and somebody that isn't. So most patients that are coma grade 3, 4 would need to be intubated for airway protection or have a GCS of 8 or less. So you can see that irrespective of the etiology of ALF, in particular, if the patient is awake and talking to you, number one, they likely have a higher probability of recovering without transplant, and furthermore, they have a lower probability of developing clinically significant intracranial hypertension. So while not going into too much detail, there is abundance of evidence that N-acetylcysteine has benefit in acetaminophen-induced acute liver failure. This is by supplementing the glutathione pathway and the conversion of cysteine to glutathione with N-acetylcysteine. And generally, there is no kind of discussion about whether we use NAC infusions in patients with acetaminophen hepatotoxicity, whether it's acute liver injury in patients without hepatic encephalopathy or true acute liver failure if they do have hepatic encephalopathy. What really is kind of a more controversial question is, what about the other causes of acute liver failure? So your drug-induced liver injury, your autoimmune hepatitis. And this was a study that Will Lee and the ALF study group did as a randomized study back in 2009. And really what they demonstrated, and I admit that the p-values are not overly impressive, but what they found was that in particular in patients with more favorable prognosis or a lower hepatic coma grade, the grade 1-2, those patients that went on N-acetylcysteine had an improved outcome or transplant-free survival compared to those that did not get NAC. So you may be aware as well that currently in Canada, we do have a shortage of N-acetylcysteine, and I spoke with Health Canada, it was about 2 months ago, and we're trying to make sure that we're using N-acetylcysteine in level 1 indications. And really at this point, what we would say is acetaminophen, whether they have liver injury or liver failure, is appropriate. If there are non-acetaminophen causes of ALF and they truly have ALF with encephalopathy, then there's an indication to give N-acetylcysteine. If they have acute liver injury from these other causes, we don't really have good data that NAC is beneficial. And we know that there's a lot of other softer indications. We've had discussions about, I've seen cases where transplant surgeons have wanted us to, somebody gets a DCD liver that has a high opening AST and ALT from preservation injury. And the question is whether we should use NAC. And a lot of these things don't have good evidence in terms of benefit. So it's just one thing to keep in mind. So neuroprotective strategies is something that is evolving. One of the good things is that we know that rates of intracranial hypertension, particularly in acetaminophen-induced ALF, and these are the patients at highest risk of developing ICH, have actually been declining over the last 3 decades. And this has been shown in data both from Europe, and this is data from the cohort from King's College Hospital in London. And we've shown it more recently with data from North America from the ALFSG registry. And interestingly enough, probably if you look overall at ALF in terms of causes of mortality, in those patients that don't survive, it's more likely nowadays to be multi-organ failure than cerebral edema. And this is one of the things that we tend to be treating better. Nonetheless, the overarching mechanisms are twofold. They're due, number one, to cytotoxic edema, or we're aware of astrocyte swelling, that you get interruptions in the urea cycle and in the Krebs cycle, and you end up with rapid accumulation of glutamine in the astrocytes, which draws in extracellular fluid. And the reason why we see this in hyperacute liver failure, and more particularly why we don't see it as often in subacute liver failure, and furthermore in cirrhosis, is because this happens so rapidly. It happens within 24 or 48 hours that you get this rapid increase in glutamine, and the astrocytes are unable to expel other osmoles to counteract this. And this is why we classically see this in acetaminophen-induced ALF. But furthermore, there's another component to this, which is vasogenic edema and loss of autoregulation with disruption of the blood-brain barrier. And part of the reason for this is that we know that ALF is a hyperinflammatory state due to a release of a lot of pro-inflammatory cytokines and damaged associated molecular proteins as the result of disorganized hepatocyte necrosis. And that's the other reason why we tend to see intracranial hypertension in a patient with hyperammonemia and ALF, and not in a patient with cirrhosis, because cirrhosis patients generally don't have that second hit, which it's not just the hyperammonemia, it's this pro-inflammatory cascade that they generally don't have to the same degree. So in contrast to cirrhosis, ammonia correlates very closely with the development of intracranial hypertension in acute liver failure. And this is one of the serial biomarkers that we tend to measure daily. And I always kind of tell our trainees here that if I could kind of save money for the lab, I would stop ordering ammonias on ACLF and cirrhosis patients and order them more frequently in acute liver failure patients. And this is an older study now, but it kind of highlights this two-hit of hyperammonemia and pro-inflammatory SIRS kind of cascade, where Will Burnell in this cohort from King's demonstrated that an ammonia level of 150 was independently associated with a higher prevalence of intracranial hypertension and cerebral edema. And the other factors that were independently associated with this all kind of represented organ failure in this pro-inflammatory state, vasoplegia needing pressors, AKI needing CRRT. Another significant component was high-grade encephalopathy. So generally, if somebody is, as mentioned before, is talking to you, it's unlikely that they have clinically significant intracranial hypertension. And furthermore, you can see here this hyperacute liver failure that we tend to see this predominantly in acetaminophen-associated ALF. So the standard kind of neuroprotective strategies, and some of this is borrowed literature from the general critical care kind of management evidence, is keeping the head of the bed elevated. We minimize things like suctioning and cough to avoid the patient straining. We try to maintain a low normal CO2 or target it to the pre-intubation level to avoid a spike in CO2, which can cause cerebral venodilation. Sedation generally certainly of agitated patients. Propofol is our first line because it's short acting and it does not confound hepatic encephalopathy. There's probably growing literature that dexmedetomidine may be safe as well, but we currently don't have a ton of data on this. But the definite no-no is to avoid benzodiazepines. Hypothermia, like other areas of or targeted temperature management more broadly, we'll talk in a little bit more detail. But similar to kind of other areas of brain injury and critical care, we know that fever is bad and preventing fever is important. Whether it's prophylactic or therapeutic hypothermia, that's a very different question. And I'll go through some of the kind of data that's been published on this. And then hypernatremia is used to kind of mitigate the shift in fluid into the astrocytes. We generally tend to maintain hypernatremia, and obviously we do this slowly if the starting sodium is quite low. For example, if it's 130, you're not going to get to 145 overnight. One thing to mention that really not only for things like managing sodium, I'll kind of explain why continuous renal replacement therapy is so important. Partly, and I'll also kind of convey that really the only way to remove ammonia in these patients is with blood purification circuits, and drugs like lactulose and rifaximin do not work in ALF. So in terms of monitoring, most centers in the world have kind of moved away from direct intracranial pressure monitoring. We do use it in exceptional cases. We actually have had one in a patient recently. To remind you that generally we're talking about, we're not talking about EVDs and draining CSF. We're talking about generally either a subdural or an intraparenchymal catheter. The only thing to mention is that you can get drift after a period of time. But we're, if you look at published evidence, this is something that we did back in 2014, where we looked at patients with high-grade hepatic coma as a surrogate of being at high risk of developing intracranial hypertension. One of the things that was demonstrated in this study, and it was a cohort study and not a randomized study, but it was from 16 different sites in the ALFSG registry, was that in those patients that had an ICP monitor put in, almost half of them had clinically significant intracranial hypertension. So at least that one could argue that at least the patient selection was appropriate. And more importantly, that those patients that got a bolt in place, most of the time this was done in association with listing for transplant, and more importantly, likely as a stop sign saying that if I put I've got concerning findings on clinical exam, if I put the ICP monitor in and the ICP is 27, I can manage this medically and kind of bridge you through a transplant. But if the ICP is 60, then obviously we have a problem and we may not be able to proceed. And we had this very recently with a case in our own ICU. But the one thing to mention was that having an ICP monitor in place was not associated with the mortality benefit, which kind of goes to the whole personalized medicine idea that this is not routine practice and not for everyone. But I want to mention as well that those patients that had ICP monitors had more ICP-directed therapies, and there is likely a role in a subset of patients. And in effect, it's very difficult to show a monitoring technique by itself in a patient that's having many different interventions done at the same time. One can demonstrate a benefit. So, the people that generally that we would put an ICP monitor in, it would be patients with high-grade hepatic coma, poor prognostic criteria. They're likely already on CRRT for removal of ammonia. They'll have hyperammonemia. Predominantly, it's hyperacute liver failure in acetaminophen patients. And more often than not, they're under 50 because these are patients that have less cortical atrophy. And it's actually generally quite rare to see cerebral herniation in patients over 50. However, probably what it has changed in our own techniques here is that there is more kind of data looking at indirect monitoring techniques. And I'll talk a little bit about transcranial Doppler and optic nerve sheath diameter. And I know that this is an area that is very strong, not only at Western, but it's an area that we have an evolving group here with Brian Buchanan and Vince Lau. And something we're doing more and more now, actually embedded in a kind of what was our old ALFSG study. We have a subset study where we're actually looking at comparing non-invasive markers to imaging and ICP measurements if they're indicated by a standard of care. So I know that many of you are very familiar with the technique of TCD, and the one measurement is the pulsatility index, which looks at the loss of compliance of the brain, for example, or furthermore, the loss of the elastic reservoir. But also there are the blood flow velocities, which are equally important to provide indirect evidence of cerebral blood flow and intracranial pressure. And I will say that with there has been data looking at optic nerve sheath measurements with the linear probe of the ultrasound, and there is data that suggests a cutoff of 5 millimeters. But in practice, we find that this is one of the most challenging in terms of intra-observer variability, where you might get one person getting 5 millimeters and one person getting 6. And does this indicate something clinically significant or not? So, the largest study that was done in ALF is not a particularly large study. This was done at the University of Michigan. And if you look at some of the areas under the curve, not surprisingly, optic nerve sheath diameter was only about 60%, which is not great. Transcranial Doppler, though, if you incorporated not only the pulsatility index, but also the flows, perform much better. And while I wouldn't say that this is a standard of care, it's certainly something that is promising when done in the right hands. And generally now what we do is we will start by doing TCDs, and if we do find something concerning, particularly in somebody where we're trying to make a decision about listing for transplant, that it may guide us with regards to information, but potentially going ahead and putting in an ICP bold. In talking about therapeutic hypothermia, the short answer is that using it, prophylactically globally, and what I mean by this is moderate hypothermia, temperature of 34, has not shown benefit in either kind of larger cohort studies like this one that we did from the ALFSG registry, nor has it shown benefit in a prospective small studies, and this was done at 3 European centers, where they were able to stratify patients between 34 and 36, but there was no difference in the significant composite endpoints. But similar to kind of the story with cardiac arrest, we're kind of learning that that while moderate, hypothermia for everyone may not be appropriate, some form of targeted temperature management is probably beneficial. And what I mean by that is that as opposed to active hypothermia, one of the things that we tend to do passively, particularly for patients that are on CRRT, is that in an effort to avoid them getting hyperthermic, is that we often turn off the rewarming circuit on the CVB HDF, certainly with the replacement fluid for the hemofiltration mode. And by doing this, often we can maintain the patient's temperature around 36 degrees. So while this study said that 34 was no better than 36, it obviously highlights that some form of targeted temperature management where you are actively making decisions, it may be better than kind of passively following a temperature and waiting for them to spike a fever. One of the challenges or the reasons why many patients either that were waiting for a transplant may fall off the transplant list is lung injury, not surprising. And this can either be for many different causes of pneumonia. Sometimes you see this with aspiration after intubation in an obtunded patient. This study really just kind of highlighted that having significant lung injury and certainly a PF of less than 200 was associated with not only lower transplant-free survival, but also overall survival. As often, this may be the reason why you can't get a patient through an operation, particularly somebody with a tight brain. Well, most of the mechanical ventilation guidelines is from borrowed literature from the general critical care population. The one challenge that you run into with acute liver failure patients is that higher PEEPs can be associated with decreased renal return and hypotension and can exacerbate intracranial hypertension. So that's really one of the few things that's different or unique to the ALF population as opposed to the general critical care population. And furthermore, passive hypercapnia is obviously a problem where in a patient with a tight brain. So in terms of volume status and cardiac output, because many of these patients have distributive shock, it is important to perform some sort of assessment. And I know that you have a very robust bedside echocardiography group, and similar to that, we're doing the same thing with a lot of using a lot of echo in terms of assessing LV and RV function and fluid responsiveness. To be honest with you, we've really moved away from doing CVP monitoring in these patients. It's only really in centers in Europe that they're using these thermodilation techniques like PICO and LITCO. I do say that using bedside echo in combination with lactate is important because really what you want to find out is if the lactate is 12, is this because of a perfusion issue or is it because of a liver issue? And that can actually get very difficult in some of these patients. The one thing to mention when it comes to vasopressor use, that there was initially some reticence with the use of vasopressin in ALF because of some small studies that said this could potentiate intracranial hypertension, but this has never really been borne out in larger studies. But really what we highlight is that generally we try norepinephrine as first line, and once we've maxed this, we would add vasopressin. We, in some cases, will target a higher MAP mainly to kind of preserve a higher cerebral perfusion pressure. And in patients with refractory shock, we tend to be fairly liberal with using, empiric trials of hydrocortisone. So, kind of the next step is what about blood purification? And there's really two things that we're thinking about here. Number one, it's the removal of ammonia to mitigate cerebral edema. And then the second thing is to remove a lot of these pro-inflammatory cytokines or damage-associated molecular proteins or patterns to mitigate the pro-inflammatory state. And really there's two roles in ALF for this, that there can be using it to bridge to spontaneous recovery, such as in acetaminophen, or in some cases as a bridge to liver transplantation. And I mentioned that probably in its simplest form, continuous renal replacement therapy is the simplest form of blood purification. And we tend to use this in ALF, not really in the setting of classic acute kidney injury, but we use it for most of its other benefits, for mitigating volume overload, acid-base disorders like lactic acidosis. And I'll show you some data on the evidence in terms of treating hyperammonemia. The reason why we like continuous therapies is because it minimizes solute shifts, hemodynamic changes, and it can mitigate ICP spikes. And generally, every time I give this talk, I get one question from somebody saying, well, Dean, hemodialysis has a higher clearance, and wouldn't this be better for clearing ammonia? Yes, it would in theory, but the problem is it tends to exacerbate all the other problems that are contributing to the tight brain, whether that be due to dialysis equilibrium or hypotension. I'll show you some data on how, if you look at practice from about 10 years ago, that unfortunately intermittent hemo tends to exacerbate intracranial hypertension, where CRRT tends to have benefit. So I want to mention that, we're all well aware that generally we tend to run our CRRT either as continuous venous hemofiltration, which is a simpler circuit that relies only on convective clearance. And as I mentioned before, in some cases, we'll turn off the rewarming circuit on the replacement fluid to achieve targeted temperature management. The benefit of a smaller circuit is the risk of circuit clotting, and some of these patients will be hypercoagulable, is less, and often we can avoid giving any kind of circuit anticoagulation, meaning we don't need citrate and certainly not heparin. Some centers, and we've actually moved to using CVV-HDF, which is a combined hemodiafiltration mode. where you get both dialytic and convective clearance. And to be honest with you, part of this was that this is our standard CRRT setup, and often this is done because of nursing comfort, in terms of you're better off setting up the circuit at the same time every way, you're less likely to get an error. As it is a more complicated circuit, in theory, the risk of circuit clotting does go up. What I do want to mention is that, the data in terms of clearance with hemofiltration, certainly, but also hemodialysis now goes back several years. This was one of the original studies that Andrew Slack did at King's that showed about a 22% reduction in median arterial ammonia concentration over a 24-hour period with hemofiltration. There was some more interesting work that was done by Ronaldo Bellomo's group in Australia, in Melbourne, where what they did is they looked at, this was a mix of ALF and ACLF patients, and what they found that whether you used hemodialysis in a continuous mode, hemofiltration or hemodiafiltration, there honestly probably wasn't much of a difference in terms of clearance of ammonia. So really the question then becomes, as mentioned before, comfort in your unit in terms of using a particular circuit setup, and furthermore, are you more likely to get away without using any kind of circuit anticoagulation? Because I can tell you that in the vast majority of cases that we run patients without anything. There is a theoretical concern with citrate regional anticoagulation that you can get citrate toxic because the liver can't metabolize the citrate. Generally, if you're only doing this for a few days, you can likely get away with it. So what about the evidence epidemiologically for CRRT? And this was a study that we published back in 2018. So we went through the whole ALF registry, and I will admit that some of the more granular aspects of the setups of CRRT were lacking. But what was demonstrated was there was a significant drop in ammonia level in those patients that received CRRT, either compared to nothing or hemo. But really what was important and what kind of highlighted our concerns with hemodialysis is that this was a multivariable model of almost 1,200 ALF patients. This was irrespective of whether you had AKI or not. And after adjusting for other markers of severity of illness, because we know that we tend to put sicker patients on more invasive therapies and blood purification circuits, that in comparing patients who received hemodialysis versus those that didn't, the odds of mortality actually went up at 20 days by 70%. So you were more likely to die on hemo, as opposed to with CRRT, where the odds of death actually went down by 50%. So this is probably the biggest epidemiological study that supports this practice for the use of CRRT kind of as your first-line blood purification technique. Furthermore, in terms of some of the more kind of granular stuff, Stephen Warrilow, again from Ronaldo Bellomo's group, what they demonstrated is probably the benefit of CRRT and ALF. You get a bigger bang for a buck if you do it earlier, and furthermore with a higher overall CRRT dose. So they were actually averaging almost 43 mils per kilo per hour of CRRT. And what they found was that the earlier it was started, the more rapid or a significant drop that they saw in the serum arterial ammonia level. So the issue is that we know that water-soluble toxins can be removed by CRRT, but the question then becomes, what about protein-bound substances? And as mentioned, a lot of these kind of substances that contribute to this pro-inflammatory cascade are not water-soluble. And I've just listed some of these compounds that build up in acute liver failure, and also in some cases in acute on chronic liver failure. So there are other blood purification techniques that generally we will use as a step up after somebody who is deteriorated potentially on CRRT. And how we differentiate them is primarily based on a few things. There are different membrane types if you look at different liver support circuits, varying based on the pore size and the selectivity, the columns and filters that are involved, the modality of renal replacement therapy that it tends to piggyback onto, whether or not you need an albumin dialysate and something like with Mars therapy, and if you need what kind of extracorporeal volume that you need. And if you look in the literature, generally, what kind of separates the different kind of techniques that are out there beyond CRRT tends to be the pore size. So So the MARS, which is a molecular absorbent recirculating system, which is an albumin dialysis system, has a small pore size. It tends to be more selective. It removes a lot of pro-inflammatory cytokines like TNF-alpha, but it doesn't. One of the concerns is, are you removing clotting factors or other immunoglobulins? It does not tend to remove these. Some of the larger, less selective modalities like plasma exchange, which I'll talk about today, tends to have a larger pore size, lower extracorporeal volume, but it does tend to remove a lot of other things. And this is the reason why you have to generally give a replacement like fresh frozen plasma. So MARS has probably been around the longest, and generally this is blood being dialyzed across an albumin impregnated membrane with a low pore size, and kind of mentioned before, the benefits is trying to remove aromatic amino acids, cytokines, and ammonia. The ammonia is removed because it piggybacks onto a renal replacement therapy circuit. It has an albumin dialysate, and that albumin dialysate is regenerated over a charcoal and anion exchange column. And then it can be run essentially on either hemodialysis or hemofiltration. And generally, how we were running this was on a Prismaflex circuit, and it can be run on CVVH or CVVHDF. So the largest study that was done in a prospective fashion of MARS was done in France, and this was the full MARS study. It was done by Fauzi, Saliba, and colleagues. And one of the challenges with this study is that if you compare Europe to Canada, for example, the organ donation rates are almost double. So, in this study, they randomized 102 patients at 16 liver transplant centers, and this is the challenge, once again, of studying an orphan disease. But the fact that the organ donation rates are so high, the timing from somebody being listed for transplant, whether you wanted to proceed or not, to the time that an organ offer came up was 16 hours. So of the 14 patients of the 53 that were randomized to MARS therapy, 14 of them actually didn't finish their first run because they got called to the OR for transplant. So that was one of the significant confounders of the study. In the overall picture, it was a negative study, but one of the questions that came up in an underpowered kind of post-hoc subarm is that there may have been a benefit for the acetaminophen patients, partly because they had a lower kind of prevalence of transplantation, and a higher potential for reversibility. However, when you looked at all of this, at that point, you were really looking at underpowered numbers with a negative p-value. However, this was a study that we did of kind of the ALFSG registry, where we looked at the 3 centers that were using MARS. That was our institution, Emory in Atlanta, and the University of Kansas. And the one thing I will mention that they all have in common is they all have an intensivist with a liver background as part of this network. And how we did this, and it was done with Andrew McDonald, my graduate student that just graduated 2 years ago, was the next best thing that we could do to a randomized study, because at this point it's very hard to do a randomized study of MARS, was a propensity match study. So we took advantage of the ALFSG registry and essentially attempted to match controls that were similar in every other fashion to the 104 ALF patients that received MARS therapy, except for the therapy of interest. So patients would have been matched on things including whether or not they received CRRT, et cetera. I will say that even in terms of doing this type of matching, if you get perfectly matched controls, you don't get a lot of them. Where if you accept that there is kind of also a compromise in propensity matching, that the more deviation you have, then the larger number of controls you'll have. What that generally means is that you have to do kind of on the back end a form of logistic regression to adjust for unmatched confounders, and that's what we did. So the bottom line is, once we did all this, MARS was actually associated with improvement in 21-day transplant-free survival, even after adjusting for the use of CRRT. And probably what was driving this was the acetaminophen subpopulation. So as mentioned before, why was this a positive study compared to the full MARS study? Well, the rates of transplant in this study were drastically different. In the full MARS study, it was almost 74%, where in this case, it was only 22%, and almost 95% of the patients that were randomized, or not randomized, I'm sorry, but received MARS, received at least 1 8-hour run of MARS therapy. So I will say, though, that while that data is promising, in the meantime, we learned kind of more about plasma exchange in the treatment of ALF. And generally, for most of us, this is something that we're running in all of our institutions. and tends to be cheaper. And this study that Finn Larson published came out in 2016. It was done in Finland, the UK, and Denmark. And what the study took almost 15 years to complete. It was a very challenging study. And the bottom line is, out of 180 patients that were either randomized to CRT or control, what they found is that they looked at two specific subpopulations, those patients that went on to get liver transplantation, and the vast majority of these are subacute liver failure. They're the slow, kind of indolent, kind of the drug-induced liver injury patients, for example. And in that population, there was no difference whether patients received plasma exchange or not in terms of outcome at 90 days. However, in those patients that weren't transplanted, where the vast majority of these were acetaminophen-induced ALF, there was a statistically significant mortality benefit with the use of plasma exchange. And I can say from personal experience, this is the reason why we switched from running MARS to actually running plasma exchange, which is what we're doing now. I will kind of give two caveats. If you look at the study design for the study, they were using very high volumes, more than 2 blood volumes. And in speaking with the investigators, most agree that probably anything beyond kind of standard TTP, 1 to 1.5 blood volumes of FFP, probably there's a law of diminishing return. So we will generally run this usually for 3 runs at kind of 1 to 1.5 blood volumes, but at this point we're replacing completely with FFP. And mentioning as well in terms of what are we removing with plasma exchange that as opposed to what we're removing with CRT, and that's kind of nicely highlighted here by they did a very nice, or Harry Antonides and colleagues did a very nice mechanistic study that showed really the benefit of plasma exchanges in a lot of removing these kind of pro-inflammatory cytokines. So probably they're kind of hand in hand, where with CRT you're removing ammonia, but with plasma exchange you're removing a lot of the markers that are contributing to this pro-inflammatory state. So really what we found as well clinically is where plasma exchange really helps is in that vasoplegic phenotype, where in some cases we've had patients that were on multiple pressors and we run them on plasma exchange while we take them off CRT for a couple of hours and run the plasma exchange. And when they come off, often the first thing that improves is their requirements for vasopressors. In terms of looking at kind of other devices overall, I just kind of highlight also the data in acute on chronic liver failure. Really, the only 2 studies that have shown any kind of a benefit was Andrew McDonald, the propensity match MARS study, but once again, this was in a randomized study, and the Finn Larson study that looked at high volume plasma exchange. And just for your reference, in patients with acute on chronic liver failure and cirrhosis, there is an ongoing study called the Apache study that's being done in Europe right now, which is looking at plasma exchange in ACLF. But to this point, generally patients with ACLF, there has been a real kind of lack of good data on the benefit of any kind of these blood purification techniques, in contrast in cirrhosis patients. So to mention in terms of prognostication, we talk about the King's College criteria. These are old. They go back to the original paper was published in 1989, reflecting a patient cohort from 1977 to 1983. And I will say that a lot of things have changed in practice. And for example, things like CRT will confound whether people ever really meet the creatinine criteria, for example. And even looking at them, you can see that there are gaps. So for example, the sensitivity of the acetaminophen or hyperacute criteria is only about 45 to 50%. So there are some people that don't meet criteria that don't do well. But we've also seen the opposite, and certainly in patients that aren't transplant candidates, that they met the King's criteria, and with supportive therapy where transplant wasn't an option, they actually survived and went out and left the hospital. And similarly with the non-acetaminophen criteria, you can see that the sensitivity and specificity are not ideal. And really what I highlight here is that generally we tend to use not one set of criteria to make a decision. The ALFSG prognostic index came out more recently, and I'm not saying that this is a one to use instead, but really it's more to highlight the common themes that high-grade coma is a prognostic factor, etiology is a prognostic factor, INR and bilirubin are prognostic factors, the requirement for vasopressors that wasn't in the King's criteria, things that are in neither one of them. Lactate is one thing that we also use as a prognostic score that's also been studied in that context. Finally, I want to mention that transplantation in acute liver failure, if you start by looking at the patients with other causes of ALF besides acetaminophen, because transplantation is much more common, Generally, the outcomes are very similar to patients with chronic liver disease and cirrhosis. And this study that was recently published in Liver Transplantation, where we went through the ALFSG registry and combined data with the big UNOS database in the United States to look at outcomes post-transplant. Generally, the one-year survival was over 92%, which is similar to outcomes in acute and chronic liver failure. But really, where there's probably more information is actually looking at what was the difference between those patients that went on to get transplanted, because the outcomes in those patients are generally good, versus those that died on the wait list. And generally those that died on the wait list had a higher burden of multi-organ failure, which isn't surprising. But probably the other thing I want to highlight is acetaminophen tends to be the toughest thing we deal with, because they have the highest rate of spontaneous recovery, but they also have the highest rate of wait list death on the wait list awaiting transplant. And these patients really can be a really difficult conundrum for us. And we had a really challenging patient like this recently. So, this is, I call this the high risk business, that this is just kind of what we do, and we're certainly not perfect. But the other thing to kind of close with is that we are getting better at this. I like to say that if this is looking at US data, again, that was also done by my graduate student, Andrew McDonald, that overall transplant-free survival in APAP ALF has improved over the last 20 years, and rates of intracranial hypertension have also declined fairly rapidly. This is in a large North American cohort. And if you look at what kind of has changed over that period of time, when we looked at this patient population, the one thing that also has changed is more widespread use of CRRT. So obviously this is a loose association and it's retrospective, but it probably shows that we're getting better overall with our neuroprotective strategies of these patients, and we're getting better at salvaging a significant proportion of them. So kind of the key points, and these are all open for discussion after this, that rates of intracranial hypertension and mortality from cerebral edema and ALF, particularly in hyperacute or acetaminophen-induced ALF, have decreased with improved early neuroprotective strategies and ICU care. Hyperammonemia in ALF is treated with blood purification therapies and not with medications like lactulose and rifaximin. Continuous renal replacement therapy has been associated with ammonia clearance reduction and improved transplant-free survival in ALF, and that was the hepatology study from 2018. Improvement in hyperammonemia correlates with early use and cumulative dose of CRRT, and that's from the studies that have come from Australia. And finally, consider other extracorporeal therapies, and mainly we're talking about plasma exchange after an initial trial of CRRT first. So that's what I have, and I hope this has stimulated a lot of discussion, and I'll just try to give you back your screen.
Thank you very much. I really appreciate that, Dr. Karvellas. That was a whirlwind tour of state of the art. So greatly appreciated. I'll just, maybe I'll go to Dr. Tang first. There are a few questions in the chat, which I can read out, or most folks can ask, but maybe Dr. Tang can start, and then Dr. Khan afterwards.
Yeah, thank you so much for that, Constantine. I'm one of the transplant surgeons here in London. I just started about 2.5 years ago, but I've read most of the papers that you published recently on this. And I met Andrew McDonald on the interview tour, so that was great. Really, really great to hear your talk. And I think for our group here, we really need to hear it. One of the other questions I had for you had two parts. I'll ask both questions if that's okay.
Yep.
One was for patients who have a detectable acetaminophen level when they arrive at your center. Do you use CRRT early in those patients, not only to clear the ammonia, but do you think it helps with the clearance of acetaminophen if it's persistent?
So that's a good question. The bottom line I'll kind of mention is there's been some data from the ALFSG registry that's looked at detectable acetaminophen levels. But in reality, because we tend to see the detectable acetaminophen levels more in the intentional toxicity cases, where in the accidental overdoses, often it's not present because they've taken the staggered overdose over several days. And paradoxically, often those patients tend to do worse, partly I think in some cases because they're not recognized by medical attention early. So the short answer is no, we don't use CRRT in the setting of clearing acetaminophen. But the point I'll probably make, which is probably more important, is that really a negative acetaminophen level is not a comforting factor, if you understand what I'm saying. That really we don't tend to use it kind of to to prognosticate either way. And often we tend to diagnose severity of ALF based on everything else. So I always kind of tell people that in some cases it's like art, that the patient may not be giving you a great history of acetaminophen toxicity, but you know it when you see it. And really it's this hyper acute phenotype of the high transaminases. And, you know, the INR is sky high, but the bilirubin isn't. Does that make sense?
Yeah, so I think what you're saying is that you wouldn't hold away CRT regardless, because if you're really concerned about acetaminophen toxicity, you're going to start it early anyways.
Exactly. I would do it for other reasons, but not based on the acetaminophen level. But really, I think the bigger issue, it's more of in some cases, we tend to get these referrals late. And sometimes it's because people are confusing it with another etiology because the acetaminophen level is negative.
Cool. Very cool.
Yeah.
The second question I have is related to the monitoring of intracranial hypertension and cerebral edema. I think we've made a lot of headway in collaboration with our ICU colleagues and the neurosurgeons, and a lot of work that Dr. Khan has done when he got here, one of our new hepatologists, on sort of standardizing the approach and getting ICP monitoring. So I think we've gotten a lot better at that. And again, it's mostly for these sort of grade 3, grade 4 patients. But then there's still a lot of controversy about the requirement for it. And so what are your thoughts on using neuroimaging as a monitoring strategy? My impression is it's not particularly good, but it'd be interesting to know what you guys in Alberta do for patients who have sort of not very profound signs or not obvious intracranial hypertension. Do you use non-contrast imaging of the brain at all, or is it kind of useless? Is what I wonder.
I think that the tough thing is often we used to say that if you diagnose ICH on a CT scan, often you've already missed the boat. And often with these patients, it can be very difficult to move them down to the scanner. So if you do have, for example, like a mobile CT that I know that some neuro ICUs have at your disposal, and you don't have to move the patient, I think it's reasonable to do something like that. What I will say is that really what most of us are looking for is a non-invasive technique where we don't have to move a critically ill patient that may be on pressors, they may be hooked up to CRT, and we don't want to, stop everything and have the concerns of putting them in an elevator. And that's really where the idea now of some of the ultrasound imaging, like transcranial Doppler of the middle cerebral artery, has probably more promise. I will say that often for either when these patients are coming through emerge, they may get a CT on the way up to the ICU, or if they're stable enough to go down, you can do that. But really kind of going beyond that in terms of the decisions around particularly in APAP patients where you're considering potentially a transplant. Often what you'll end up doing is if we have a very concerning sign on a TCD, for example, that will be more of our decision to put in a bolt, for example. So in terms of truly putting an ICP monitoring, that's kind of only in a minority of patients. And really, I think where the most again is probably doing more of this kind of non-invasive stuff, particularly with I'm not saying TCD is the be all and end all or something like that. That is non-invasive.
So just to make sure I get this correctly, that if you can get away with a non-invasive monitor, so be it. But in a patient where you're really trying to make a difficult decision about their eligibility for a transplant, they've kind of declared that they're not going to recover, and there are concerns about elevated ICP, that you would still consider a bolt in those patients to help you make that decision.
I think if you had, I think there isn't really one way to do it, but if you have a reassuring TCD, and let's say you had a CT scan that was reassuring, and you don't really, the liver is not recovering, but their pupils are reactive based on your TCD, or your ICP is less than 10, you're probably okay. But really it's the ones where you've got a concerning TCD. And as I mentioned before, is the ICP 20 or is it 60? Where if it's 60, you're not going to go ahead with a transplant, where with 20, you might gut it out, and we've gutted out patients like that. That's really where the role of the ICP monitor is.
Okay, very helpful. Thank you very much.
I think Dr. Khan had his hand up, and then I'll get Dr. House if he's there.
Thank you very much for that talk, Dr. Karvellas. My name is Qasim Khan. I'm one of the newer hepatologists here. I appreciate you spending your time to give us this talk here. And as Dr. Tang mentioned, we've been trying to streamline our process here in terms of managing these very, very sick patients. I didn't have my hand up specifically. I was just applauding, but just you did give me the opportunity. You know, a lot of the data with regards to CRT, and I think the Cardoso study, which you were obviously a very important part of, had left some very important questions in the end in terms of, you know, that there's certain nuances, and I think you spoke about it, like granular details in terms of early versus late, in addition to even looking at the type of fluid that you're using, and then also the rates and the stoppage time. So you did mention some of the studies today in terms of the flow rates from some of the groups in Brazil and in Australia. But in terms of cutoff points, in terms of when you're going to be stopping CRT, from your expert standpoint and in your institution, when you are using CRT, what are some of your stopping parameters?
Yeah, so the starting, I would say, is the easier part. And generally, we'll do it in most cases with anybody with an ammonia greater than 100. We start to kind of get concerned, and certainly in those patients that are obtunded, that have high-grade coma. The stopping part, generally, in most cases, we would want to be seeing somebody where there's evidence of hepatic recovery. So if you had somebody in the unit, they've woken up, their INR has near normalized. It's in those cases that we'll start to kind of back off on a lot of these techniques, and that's also your other neuromonitoring techniques. Right. So really, at that point, we would kind of make the decision to give them a filter holiday, where we would take them off of CRT for 24 hours. Also, in many of those cases, they will make urine, so that's the other thing. And probably the only other thing to mention, that you get sometimes this rare phenotype of what I call acetaminophen nephrotoxicity, where everything else gets better, and then the kidneys are actually are still offline, and you take them off CRT and they're anuric. And really, that's when we would transition to hemo. And in many cases, these are when these patients are going out to the ward, is that they've had neuro recovery and hepatic recovery. And really now it's just the kidney that is and generally that will recover with time. But that's one of the things that we'll look at. So, and often that's the only case that we're actually transitioning them from CRT to hemo, is either was there a component of any kind of hit to the kidney, or is it acetaminophen nephrotoxicity? Because in many cases, you'll often be able to get them off CRT, and then there's no issues from a renal point of view.
Perfect. Thank you very much.
Dr. House, did you want to go, and then Dr. Leibowitz?
Yeah, just I'll state my bias right away, that I'm a bit of a skeptic at this whole thing. And I think the easy thing for us, Dean, is when the patient has AKI. And there's no question, we come in and we help, and we're happy to do that. Where I have difficulty is trying to understand when the patient has normal kidney function, and therefore has a GFR and an ammonia clearance in the triple digits, how adding CRRT at 20 mils per minute is going to make any difference at all. And I've spoken to Andrew Davenport and others about this, and as somebody that does dialysis for a living, intermittent dialysis is an effective way to remove ammonia, and there are studies that have compared the two. And yet I share your concern about doing IHD in somebody whose brain is a little bit tight. And so that's the conundrum for us, is when we come in and the patient has some arbitrary number, is otherwise well, is making lots of urine, has excellent kidney function, and we're sticking a large bore catheter in the neck and confining them to CRT without really believing that it does a hill of shit worth of good. And now we're adding plasmapheresis to that mix, which is really beyond the pale. So
I guess, Andrew, what I would say is two things, is that we remember in that multivariable study, so that was our study in pathology.
And I know it well.
And that was after adjusting for severity of illness. There were people without AKI, and they had benefit even in those patients with CRT. So
but even the figures from that, and it's a great paper, but even the figures that show what looks to me like regression to the mean. Yeah. Everybody's ammonia drops with or without any renal replacement.
And I'll say too that the limitation of that is that we only had about 300 patients to do the kinetics on, and that was due to missing data. That wasn't due to a lack of efficacy. I think I just want to mention. But really, what I would say is that I'm not, in terms of what we deal with most of these patients, honestly, the dialysis catheter is the least of our concerns. And because some of these patients are actually hypercoagulable, and like I said, I'm doing this myself. Like, these are we run our own CRT and hemo in our unit. And, like often we're able to, if somebody has an INR of 4, but a normal platelet count, often we can put in a dialysis catheter without giving any product. So for me, that's not a big, like, I think it's a bigger concern with the ICP monitor than it is with a dialysis catheter. But really, I think there's more and more evolving evidence that certainly if you take it into context with the data from King's, and certainly now that there have been further studies that have come from our network that show that really the one big change that there's been in terms of practice has been more widespread use of CRT, and patients are getting better. That I think it is certainly adding something. And I think I'm not talking about these healthy patients that are doing well. I'm talking about disasters, and where we are in some cases chasing our tail because now we're on 3 pressors. And I can tell you plasma exchange really has a benefit at that point. And partly it's also to protect the brain because now it's also, you're not being able to maintain a cerebral perfusion pressure on top of that. So like I said, I think also if you go to most of the, in my bias, I trained in the UK, but if you go to most of the major transplant centers, certainly in Europe, they're all doing this. So this is not, I would say that this was actually a practice that was being done for many years that the actual evidence followed. So that would be kind of my answer. So I understand your concerns, but I would kind of come at it from a different, my experience has been different.
Dr. Lidowich, you want to ask your question?
Yeah, first of all, thank you so much for a great talk. I learned a lot. I just wanted to go back to one of your first slides where you first distinguished that, there's a difference between acute liver failure and acute on chronic liver failure. And I just wonder whether you could comment on the differences that you would have to approaching CRT and ICP monitoring in those 2 different patient populations. So I think, as you mentioned, we see the chronic patient population who develops liver failure much more frequently, yet we still start a CRT on them, individuals who presumably have chronic ammonia elevations and therefore probably some, adjustment to the astrocyte engorgement, so to speak. So I was just wondering what your thoughts there are about urgency of CRT and continuing it before surgery and during surgery, as it's a limited resource in our institution. And then the same question around ICP monitoring and what your thoughts are about, that the more chronic patient population.
So I'll try to give it as a fairly simple answer. So the difference is that generally ACLF patients do not get intracranial hypertension. So we do not use CRT in that setting as a neuroprotective strategy because they've gone on for this period of time. Hyperammonemia is not associated with even hepatic encephalopathy grade in ACLF. So ACLF, if you're really looking at the evidence for initiation renal support, it's 2 things. It's the START AKI study, which really shows that there was a subpopulation of cirrhosis patients in that study where there's probably no benefit of accelerated renal replacement therapy. So all the stuff that I'm talking about here, that is not the case in ACLF. In fact, it's the opposite. I think in an ACLF patient, often you have time to make that decision. So in an ACLF patient, the decision is really around AKI and complications of AKI. So where that may come in, and I didn't really discuss this today, is if you're bridging somebody to liver transplant, where issues perioperatively may be around if somebody is anuric or very oliguric and they can't manage the hyperkalemia, the fluid overload, or a lot of the metabolic changes with when you take an organ out of cold storage, even though we're using more of these ex vivo circuits, dealing with that, then there may be a benefit to put somebody on renal replacement therapy pre-transplant to make your anesthesiologist happy by taking fluid off, running the potassium down so they can deal with that during transplant. Or in the other setting that, for example, we do preemptive CRT, before transplant in somebody with AKI, but furthermore, we even do perioperative or intraoperative CRT sometimes as well. That is a much more difficult question. And what I would say too is that at this point, there's no role for plasma exchange in ACLF. So all of these therapies are only in acute liver failure. The neuro issue is an acute liver failure issue. It's not an acute on chronic liver failure issue.
Well, that's really helpful for us all to hear, I think. And what about the ICP monitor question?
Yeah, there's no role for that in ACLF.
Okay, that's really helpful. Thank you.
Yeah, I appreciate all the questions coming in, and I'll try and continue to get to them as long as Dr. Karvellas will entertain us. Maybe I'll just go to Dr. Slezrev because his hand's up, and then if we run out of questions, I'll go into the chat. But Dr. Slezrev.
Dean, great to see you, and thank you for a great presentation. I really just have a question about monitors. I'm I'm reluctant to put invasive monitors in. So two comments caught my attention during talk. First one was about CVP in these patients. And I know this has been a practice in liver transplantation for a long period of time. We've moved to an era where we're doing a lot of these POCUS assessments of RV, LV function, shock. We can even compute non-invasive cardiac index using VTI measurements to assess for shock states. So I wanted to hear, what proportion of patients actually get routine CVP measurements? Do you target your resuscitation to CVP, or is it primarily echocardiographically driven? That's question number one. And the second one is about ICP monitoring in acute liver failure. What I'm hearing is you sort of have a sequential approach where you basically use clinical assessments, looking at pupils and so on. And if you can't assess that, then perhaps use a TCD as an adjunct. And if you have sort of high pre-test probability, then in comes the ICP monitor to basically risk stratify. Is that fair?
Yeah, no, and that pretty well sums it up. So I think the first point, we're not prescriptive in terms of telling colleagues not to, if someone's comfortable with CVP monitoring or pulse pressure variation, so be it. What I'm just mentioning is now, certainly in our unit, there's been a higher kind of shift towards the use of bedside echocardiography, because the biggest concern in an ALF patient is fluid overload, that you could exacerbate some of these complications. And a lot of them will be vasoplegic, irrespective of how much fluid you give them, because it's their liver failure that's driving their vasoplegia. So that's the one issue. And really, I would just say, use what is the most comfortable to you. But I know that, like, obviously one of the biggest evolving factors in critical care, and I know that this is one of London's strong points, is actually your bedside focus group and using this, because you can get dynamic information and make changes based on that information. I think what you're describing is very important, is that really, I would say that probably the bleeding risk with ICP monitors is less than what was previously reported. It's probably less than 5%. We haven't actually had a clinically significant bleed with an ICP monitor. Something we were part of was a study looking at TEG and ROTEM, or viscoelastic testing, to assess clotting. And this actually gives us information in terms of those ALF patients that are hypercoagulable. And in some centers in the US, for example, they would use that as the decision maker with regards to actually putting in a bolt without giving blood product. I will say that in the last time we put a bolt in, the patient happened to be on plasma exchange already. And I will comment that one of the limitations of plasma exchange is you lose the INR as a prognostic marker, and you need to tell your surgeons that you're going to fly blind for a couple of days because of the blood product. But also, that's often the time, if you're going to put a bolt in, that's probably when we would do it. But generally, as you've mentioned, it's clinical suspicion, high coma grade, high ammonia level. If hyperammonemia, and if they're grade 4 coma, at that point, probably we would be doing TCDs on top of clinical exam. If that was, comforting and they don't have any other clinical signs to suggest intracranial hypertension, we probably would follow. And then hopefully, you're hoping in 24 to 48 hours in the APAP patients that the liver starts to recover. But if that's not the setting, or you see some other clinical change, really the next step, certainly if also the liver is not recovering, and now the surgeon's knocking on the door saying, are we going to list the patient or not? I really want to know that they're not herniating. Then you need that ancillary information, and that could, certainly that's where we would consider putting in a bolt.
I'll go to Dr. Bosman, then I see Dr. Khan's hand up again. So I'll go to Dr. Bosman first, and then come back to Dr. Khan.
Hi, Dean, can you hear me?
Yeah, I can hear you, Karen.
Okay, perfect. Great talk, thank you. I had a question about the data you presented about the ICP monitoring from the registry. About half of patients had ICPs less than 25, you said, and half then, I guess, greater than 25. So I can understand the need to monitor ICP when you're high, and you want to know how high is it, it's going to preclude transplant or not. But I think we kind of maybe fail patients if we're putting them in the ICP 6. So I was wondering if there's more data available to differentiate. Were there other signs to differentiate the patients that had high ICPs from the low ICPs before they went in? Is there anything to help us guide in that way?
So unfortunately, not from that. It's a good question. Not from that particular study. And I will say that The bias probably from that study is that I will say when we actually looked at the individual centers, there were actually variation in practice where there were some centers that were very aggressive in terms of putting ICP monitors in, and then others that weren't. So I think indirectly, I think this has more to probably kind of plays that there was this, I would just say that there were significant practice variations. And that's why one of these things, it's very hard to kind of assess this in a cohort fashion, but the problem is because we have really limited data. But I think that's why now, and also if you look at the timing of a lot of that information, a lot of the non-invasive kind of techniques were not available. And I'm not saying they are a replacement or a standard of care, but it kind of highlights to avoid putting an ICP bolt in somebody with an ICP of 6 is the fact that if they most likely will have a reassuring TCD or some other kind of non-invasive measure, that at least now there's another additional kind of metric you have to meet to say that, yes, you have your high-grade coma, but everything else looks good. You're hemodynamically stable. Your TCD looks good. You had a screening CT scan when you were admitted that was normal. You don't need an ICP bolt. And I think that's really what we're getting at, is probably going forward, having some kind of it's kind of a stepwise process or a step-up process in invasiveness. And also we say in terms of even looking at the blood purification, that's a step-up process as well. That our last APAP patient ended up on nothing, and we just monitored him for 48 hours in the ICU. We came in with an INR of 7, and because everything else looked favorable, and he left the hospital. So I'm not saying really it's the personalized medicine aspect that you're titrating it to the patient that's in front of you.
Dr. Khan, do you want to come back in?
Hi there, this is JPR. Hi, Dean. I'm Dr. Khan assistant. Basically, I agree with you in this comment of the personalized medicine in the sense that we need to recognize if this is a patient with ACLF that is going to recover, or we are thinking that the patient may recover. And it's different from the patient that we already listed for transplant. Probably in that patient, we would like to be more aggressive on the monitor, including ICP monitor, because things can change, and then we don't want to put a new liver in a patient that will have some bad neurological outcomes. We have had those cases, and I wanted to make the comment because it's different from that patient that is acetaminophen and you are doing NAC and you think that it may recover, and you are following from a neurological standpoint, because the clinical examination is very difficult. And when you have symptoms or sign of intracranial hypertension, it's probably too late and you miss the train if you are going in the transplant road. So that was my only comment.
Yeah, no, I think what you're highlighting is important. And I just want to mention too that even in like the most skilled hands, there are a lot of gray areas with this. And there are, I can tell you, like, some of the most frustrating cases I've had have been in the last month. And I think I'm probably smarter than I was 10 years ago. But there are cases where, we had a lady that was 50 that by all the criteria, she should have recovered, and her lactate went from 20 to 4. And she had very reassuring ICP markers, and then all of a sudden 2 days later, her TCDs were very abnormal, and then we enlisted her for transplant, and 12 hours later she herniated. And I just want to mention that was despite doing pheresis exchange with CRT pheresis with improvement. So these are very difficult situations. The other thing too with the ICP monitor, is it going to change management? And somebody that's not on the transplant list, if based on the TCDs that you have intracranial hypertension and you're already on CRT plasma exchange, you've given hypertonic saline, you've probably given a bolus of mannitol. If an ICP is just going to tell you what you already know, then why would you do it? And I think that's what really highlights why the real difference in, as you mentioned, is for that person on the transplant list, is to tell the surgeon, we're not winning. I can't even keep them alive for 24 hours. So how am I going to gut them through a 12-hour operation where they're going to be lying flat and get an ischemic liver and deal with this?
Just, I'll go to Dr. Ludwig in 1 second, but there's a question in the chat I might read out from Matt. I'm not sure if that's Matt Weir, but are there ALF patients in whom CRRT would not be indicated?
I think it's just that if they had the criteria that we discussed, probably I can't think of any, but always just remember again that we're really talking about the hyperacute subpopulation. It's really the acetaminophen patients, and these are the ones that are at the highest risk of intracranial hypertension. We're not really talking about the, there are some, as Juan and the liver group probably know, there are some of these patients that have subacute liver failure that never end up in the ICU till after their transplant. So really, we're talking about really kind of this really challenging subset population, which makes up about half of the patients.
And Alex, do you have a question?
Yeah, I know. I just wanted to also just mention another caveat of the ICP monitor. When we have reassuring clinical signs, and then we instill an ICP monitor and we see that the ICP is 30 or 40, and we prematurely terminate care when the outcome might have potentially been favorable. We've had that also occur, and without it, the patient might have survived. So I guess it's hard because sometimes we make the wrong decisions even when the monitor is in place.
Yeah, but I would say this, that like I haven't, I think an ICP of 30 is in the area where you're going to try to medically manage it and bridge the patient. I don't know also if you're talking about in the absence of transplant, if somebody wasn't a transplant candidate, because for us, really, it tends to be pretty blatantly obvious that the TCD and the ICP monitor are giving us very similar information, because otherwise I think you need to check your probe.
And then
I'm just going to say that we've seen this in trauma population too, right? You have an ICP, BALT or subdura, whatever monitor, and it could be reading 120 and the patient could be, doing completely fine, right? So just because you have a monitor, there's so many things that can go wrong with a monitor that, you have to look at the entire patient. Do you have pupils that are reactive? Do you have reassuring TCDs? And does everything align essentially? So that's just be very careful with a single reading.
I agree with you, but I think too that also I think one of the things to highlight with this is it's only a very small population of patients that get bolts, and at that point really you're doing it because of all the other concerning pieces of information. So often that is really just kind of confirming everything that you know already, and really it's just that's why I think, to be honest with you, I haven't had a case of somebody with a ALF, certainly with a bolt, that gave us aberrant information, because we had all those other pieces of information, or we probably wouldn't have gone ahead with it to begin with.
So there are just two more questions, and I might cap this off and let Dr. Karvellas get on with his night and not ever watch the Leafs game. But two questions in the chat. One from Powell was Plex increases infection risk. Are there concerns about this?
So not really to any, I would say to any significant degree. And really, I didn't have time to put this on the talk, but really the ALF patients that are at the highest risk of infection are actually the subacute liver failure patients. And the reason why is that those patients often grumble along for weeks and often can end up with a bilirubin of 500 or 600. It's really these patients with these really cholestatic livers that tend to die of bacteremia. Really, with ALF, it's your liver failure or your brain that kind of predicts how you're going to, or really where your outcome is going to go. Where really with these subacute patients, because the vast majority of them are all kind of sitting on the transplant list waiting for transplant. Those that really die waiting for a graft, often it's because of sepsis and multi-organ failure.
And then Ravi Teja asked, is intraoperative ICP monitoring useful?
So if they have a bolt in place, we'll monitor it during the transplant. We'll continue it. But generally, if there wasn't an indication to do it before transplant, generally that hasn't been our practice to do that. And obviously that's an important question.
Okay, I may have lied. If you have time for one more question, Dr. Karvellas, Ephraim Tang just has his question up again, or hand up again, and then we will close after that. Is it okay to have one more?
Yeah, of course.
Yeah, perfect. Ephraim?
Well, thanks so much for everything. I think we have learned so much, all of us here. I think the one thing to contextualize from a transplant practitioner point of view is that we have to meet the high standard of allograft utilization. So when we're making these decisions about when to proceed with transplant, remember that from our perspective, it's not just the patient in front of us, but it's the other patient who's not getting a transplant. And so I think, the real question for us when we're asking for a bolt in a patient who has a very concerning picture, obvious, or the anticipated trajectory is non-recovery of the liver, that we are not engaging in a futile transplant. So our requirement for as close to absolute certainty we can get for a normal or at least a tenable intracranial pressure to justify a transplant is the highest. We need the closest we can get to absolute truth in terms of what is going to happen to this patient, that there will be a favorable neurologic outcome. So I think surrogates end for us at that point when we're making that decision. So I think in a patient who is going to recover, yes, there's no role for a bolt. But if we're going to transplant this patient and there are any concerns about their neurologic viability, the burden of proof is much higher. And I think based on what you've been saying, Dean, I think you agree. So tell me if I'm wrong.
Yeah, I mean, and that's really what the data was from that study that we did in 2014. That really the vast majority of bolts are actually put in patients on the transplant list. So that's a good point.
All right. Well, we're coming up to 6:25, so I'll draw this to a close.